Доброго вечора, українські радіаційні онкологи. Слава Україні! Дуже дякуємо, що приєдналися до Case Review with ASTRO Experts для України. Today we have a session on upper GI tumors, and we have two excellent speakers, Dr. Parikh from US and Dr. Zoya Shepil from Ukraine. Dr. Parikh is the director of MR-guided radiation therapy and GI radiation oncology at Henry Ford Hospital in Detroit, Michigan. He's been researching and implementing methods for prevention of overradiation of the stomach or intestines while treating abdominal tumors. He has run clinical trials in pancreatic, liver, and rectal cancer. He also researches methods to hypofractionate GI radiotherapy. He completed his training at Washington University School of Medicine and served as an associate professor there prior to joining Henry Ford in 2018. Dr. Parikh holds roles with several prominent academic organizations such as National Cancer Institute Pancreas Cancer Task Force, ASCO GI Faculty Committee, and NRG Upper and Lower GI Clinical Trials Focus Groups, and also ASTRO and APM. Welcome, Dr. Parikh. It's an honor for us to have you here. And our second speaker is Dr. Zoya Shepil. She is an active Help Ukraine group member and a radiation oncologist at Shalimov Institute in Kyiv. She has more than 25 years of experience in radiation oncology after graduating from Luhansk State University. After Luhansk became occupied by Russia, she lost her home and had to relocate to Kyiv. And she worked at Kyiv Regional Oncology Dispensary and now started working at Shalimov's National Scientific Center of Surgery and Transplantology in Kyiv, Ukraine. She's one of the leaders of radiation oncology in Ukraine, speaking at the national and international conferences. She also volunteers for Help Ukraine group, organizing and training courses such as HUG OncoHub Radiation Oncology course that will start October 17th. We are very grateful to all you do, Dr. Shepil. So we're very excited for today's Upper GI lecture. Dear speakers, the mic is yours.
Let me go to the next slide. And thank you so much for that kind introduction. Dr. Shepil had kind of wanted to set the stage, and I think has a nice few introductory remarks.
Yes, thank you very much for opportunity take part in this discuss. The topic today is challenges in the treatment of upper gastrointestinal tumors. The radiation treatment options for upper gastrointestinal cancer is not very common in Ukraine. Why reason of this? Lack of equipment, controlling setup of the patient, and lack of equipment of motion management. Because in this area we have a lot of organ of risk, liver, stomach, pancreas, liver, kidney, and other. Also, most studies and protocols suggest systematic therapy for GI cancer. Lack of experience to treatment the upper part of abdomen with radiation therapy. As a result, there is a fear to taking those patients for radiation therapy treatment. Such restriction in the use of radiation therapy of this case is not only in our country, in other low and middle income countries also have some restrictions. About this situation, in October 2023 was published the paper elucidating the benefit of radiation therapy in GI cancer, rethinking trial, endpoints, and patient selection. The improvement of technological opportunities in radiation oncology challenges the role of radiotherapy in many tumor sites. Upper GI tumors share a very unfavorable prognosis, and in the meantime, they could benefit from technology innovation. In graphic, you can see a lot of trials about systematic therapy and very small numbers of trials about radiotherapy. What is the role of radiation therapy across GI cancer sites? Based upon the ASTRO result, one might expect the oncological community to believe there is little to no role of radiation therapy across GI cancer sites. With these questions in mind, I would like to invite our ASTRO expert, Dr. Parikh, for presentation using clinical example to have better understand in these cases better to apply radiation therapy. Thank you, Dr. Parikh, and we look forward for your presentation.
Thank you very much, Dr. Shepil. Let me just adjust the slides. Okay. So I'm going to just speak of a couple of aspects. One, I'm going to talk about respiratory motion. We'll talk about liver cancer and pancreatic cancer. We'll then go on where Dr. Shepil has a case with esophageal cancer that I think is also very relevant to the audience today. So why do we worry about respiratory motion? The upper abdomen tumors, these are some clips that are in the liver that we took some fluoroscopy. You can see that there is a lot of motion of these tumors, and this makes it very challenging to appropriately plan the radiation in this area. I did have my first question to understand from this group, what motion management is available to you? So here we have the questions. We're looking at, is there no motion management, 4D CT, breath hold, respiratory gating?
And you can select everything that applies to you. So there's a multiple choice and you can select multiple answers.
So let's see if we can get to 75% of participants. We're getting close. Okay, we are there. So I will go ahead and end the poll. Oh,
So I will be operating the poll. You don't need to worry
Oh.
about it. Yeah, go ahead.
perfect. So do people see the poll results then on our screen? It looks like it.
Yeah.
So it looks like half of the participants do not have any motion management opportunities in their clinic. Others have 4D CT. And then there are some people who have some breath hold or respiratory gating or abdominal compression. So this is good. We can talk about some of the uses of these techniques. Can I close the poll, Natalia? Like
Yeah,
close
go
the
ahead.
window?
Close,
Okay.
close the window.
So one thing we're going to discuss is the difference between passive motion management and active respiratory motion management. Passive motion management is just the use of measuring the motion. This can be done as simply as asking a patient to take 2 CT scans for simulation, one where they inhale and one where they exhale. And you could fuse the 2 CT scans together to show where the tumor is in both spots. But you're not intervening on this. A more active way of measuring the same thing is to do a 4D CT. This is the use of a CAT scan that at the same time you acquire the CAT scan, you're acquiring the respiratory waveform, and the CAT scanner will bin or separate the images based on where in the respiratory cycle the patient is. Most commonly, say for lung cancers, we end up putting these different images together and create the ITV. The ITV is a measurement of where the tumor is in all the phases of breathing. So that's passive. In the upper abdomen, we do try to avoid using the passive methods for accounting for respiratory motion. This is because in the upper abdomen, the organs at risk, like the liver and bowel, is very close to your targets. And so using an ITV-based approach or passive management approach can be more risky for problems. So when we talk about which ones are active, we're going to look at respiratory breath hold, gating, and compression. One thing that does make visualization in the abdomen more easy is the use of fiducial markers or clips from a surgery. These are, there are some custom fiducial markers that you can purchase, but other times we've just had radiologists use whatever clips or surgical clips that they have available. You can implant these percutaneously. In the case that I'm showing over here, this is an implantation into the pancreas. So this was done endoscopically via endoscopic ultrasound. And I think the important thing to realize in the upper abdomen is you don't need more than 1 or 2 markers, because if you have too many markers, then you can create a metal artifact. And you don't need it to bracket the tumor. You can always measure where the marker is and where the tumor is. One can see that in this patient, we can see that on the planning CAT scan where the marker is in the pancreas and it's in the neck of the pancreas adjacent to this pancreas tumor. But on a cone beam CT, you would not be able to see all of that, but you can see the marker very clearly. Now, in pancreas cancer, we have a lot of patients who already have some metal marker in them. They either have a tube to drain their bile duct, a percutaneous biliary tube, or more commonly, we have patients with biliary stents. These, we can feel very confident that the inferior part of a biliary stent is right near the pancreas head. This is not as accurate as fiducial since this is in the bile duct that's close by to the pancreas, but it's much better than trying to view the images just without any fiducial. So this is probably, the biliary stent is probably the most common fiducial I see in my patients, as that I do take care of a lot of pancreas cancer. Active breathing hold. This is an example of one such device that has a valve for the patient's nose. And so you have the patient hold their breath like you would with the system that you would go swimming underwater with. And the system locks a certain amount of air into the patient. And you can see this at the treatment console and set your treatments to be at the time of that breath hold. At our institution, we are more likely to use this active breathing control or breath hold for patients with breast cancer, especially left-sided breast cancer. And I don't use it as much in my patients with abdominal cancers. A more technical approach is to measure a respiratory signal while you're doing the radiation. This is one such system here to the left, using a cube that's placed on the patient's abdomen, and the patient's then position is noted during breathing, and you get a waveform like this. This is a system here that uses a surface. It uses cameras to watch the surface of the abdomen or chest directly. It also creates a waveform. There's also belts, pressure belts that you can put around a patient. And then this also, the pressure belt will measure the change in abdominal circumference. The biggest challenge with any of these systems, but I would say especially these systems, is that when somebody looks at a signal like this or like this, they can think they are actually looking at the tumor, but this is not the case. This is only a measurement of breathing. And each day you have to make sure that the breathing position and the tumor position match in the same way you thought it would. Just think about me as a speaker. You can say that the picture where you see me in the center of the screen is my position, and I'm breathing here in this position. Well, if I move over here, I'm still breathing the same way, but obviously I'm not located in the same section. Now, a tumor cannot move that far, but it can move pretty far, and there can be changes in this breathing relationship to where the tumor is. One of the most common techniques that we use here in our clinic is abdominal compression when we're using it for abdomen patients. This is the use of either a block that pushes on the abdomen, or we use this type of system, which is just a corset. It's just a band or belt that goes around the abdomen. Why do we like this system? It is the least expensive system out of all of them that I found, and it's very practical to use. It also has the least amount of challenges in the complexity of the simulation. You just put this on as tight as the patient can tolerate it, and then measure your CT in that position. There can be some challenges that it can push contents of the abdomen. Sometimes it pushes the tumor and organ at risk closer, but at least then it's in a known area. So I would say out of my patients that I'm treating on a standard LINAC, where I'm using some sort of breathing control, I'm most often using abdominal compression or using the surface gating. How does this show up on a cone beam CT? This is a patient I was setting up for pancreatic cancer. We can see the stent, and with compression, we can see that the stent was in the correct place. Without the compression, you can see here inferiorly that sometimes the stent is outside of the planned area. I think the easiest way to understand whatever motion system you're using is with a direct visualization into the patient. In our newer radiation oncology equipment that comes with KV imaging and does cone beam CT, which I know unfortunately is not available to all of the participants today, you can basically redo a conventional simulation. I know that many of you do have familiar with a conventional simulator, and this is just using the same idea of a fluoroscopy, a virtual beam's eye view, to make sure that your treatment's in the correct place. So here you can see the stent. We made an outline of the stent, and you can see that the patient is breathing, and that where they're breathing right now, sometimes it's within a planned area around the stent. That's this outside green area. And sometimes if they take too deep of a breath, it's going to go outside of that area. So what I do is in treatment planning, I would have drawn the stent. And so this area here, this inner green part was where I drew the stent, and then I expanded it. And this basically margin that I put on the stent instructs the therapist on how I want to set the patient up each day. And whether then you have to change that relationship with the gating, whether you have to tighten the corset, whether you have to change how the patient breathes for that breath hold, you can use whatever system, but the X-ray fluoroscopy image of the patient makes it the easiest to evaluate. So let's go to one of our cases. This is a 70-year-old, 4-year-old patient who presented with painless jaundice and dark urine. They were noted to have elevated bilirubin, and imaging showed a pancreatic mass. An ERCP was done, and a stent was placed. An endoscopic ultrasound showed a 3 by 3.2 centimeter mass in the pancreatic head, and biopsy showed this was adenocarcinoma. I've put some key images of the CT scan here. Up here on the left, we see that the tumor has changed and narrowed the portal vein. So here's the portal vein, and here's another slice, and you can see that the caliber of the portal vein has really decreased. The other thing is over here, what we're seeing is the common hepatic artery. And here you can see tissue that's right nearly encasing the common hepatic artery. You see tissue here that's encasing the common hepatic artery. And the involvement of the common hepatic artery, as well as this involvement where this was not something we thought we could reconstruct, this led to the diagnosis of locally advanced pancreas cancer. There were no other metastases found on imaging. Okay, so locally advanced pancreatic cancer question. What is your preferred management for this patient? Hospice, 70-gray chemoradiation with cisplatin, surgery, or gemcitabine nab-paclitaxel? The participation is really good, you know, Natalia, for making sure that we enroll the participation with these questions. Thank you for doing all these translations at the last minute yesterday evening.
Yeah, no worries.
All right, well, we are above 75%. So if you want to, we can end the poll. So let's talk about these different answers. So we have a lot of people who offered chemoradiation with cisplatin to 70 gray. Then chemotherapy, then surgery, and then chemotherapy. Close the poll. So let's look at the correct answer. Hospice is something we would consider for patients with a poor performance status. This patient's performance status was fairly good, PS1, and so we did not recommend hospice, even though the patient's chance or survival rate with this type of cancer is probably a median survival of around 20 months and a 2-year survival of about 20 to 30%. 70 gray of chemoradiation with cisplatin is something we would do for head and neck cancer. It is not an appropriate radiation dose for pancreas cancer, and cisplatin is not the preferred method with chemotherapy agent that's used with chemoradiation. Gemcitabine nab-paclitaxel is a standard first-line treatment. There are 2 such treatments for pancreatic cancer that are recommended in patients with good performance status, either FOLFIRINOX or gemcitabine and nab-paclitaxel or albumin-bound paclitaxel. These are kind of the guidelines that are in pancreatic cancer for locally advanced with the good or intermediate. Systemic therapy or induction chemotherapy, and we only use chemoradiation or upfront SBRT in patients who are not candidates for induction chemotherapy. The chemotherapy that's used with radiation in patients with pancreatic cancer is either 5-FU or capecitabine or gemcitabine. Cisplatin is just not utilized. And we don't tend to use the 70 gray and 35 fraction regimen either. We'll talk about some other regimens to use. So this patient underwent 4 cycles of gemcitabine and nab-paclitaxel. This was stopped after development of pneumonitis, and the tumor was found to still be unresectable. Because of the pneumonitis, she no longer felt as good and was independent as before the chemotherapy, so maybe PS2. And she was referred for radiation therapy. She wanted to continue some type of treatment. She did not want to go to supportive care or hospice. So as she was sent for us to consider radiation therapy, we decided to plan a nominal dose and nominal means an approximate dose of 50 gray in 5 fractions. And I'll show you our thought process behind that. So unfortunately, there have been many studies of radiation in locally advanced or even borderline resectable pancreas cancer. And when we use a standard dose, and a standard dose for SBRT would be 33 gray in 5 fractions, so it's a very moderate dose. Or for fractionated, this would be 50 gray in 25 fractions. We see no improvement in overall survival. The study here on the left was looking at patients with borderline resectable pancreas cancer, and it randomized them between FOLFIRINOX versus FOLFIRINOX plus the standard SBRT, and you can see there's no change in overall survival, maybe even a little bit worse with the radiation. This study on the right, a much bigger study, is called LAPO-7, run by the French. And this randomized patients after chemotherapy and didn't have progressive disease to continuation of gemcitabine-based chemotherapy versus 5-FU radiation or capecitabine radiation. Again, no difference in survival at all. So there is a reason we don't use much radiation in upper GI cancers, as Dr. Shepil said. The data does not look very promising. This was a study that's led to kind of these current thoughts of higher doses of radiation for pancreas cancer. This is from MD Anderson Cancer Center in Texas. It was a retrospective study where they found some patients, heavy, big patients, where the tumor and the stomach or intestines were far away, and they increased the dose there. And they found that there was maybe an improvement in 2-year and 3-year survival, not at 1-year survival. Patients passed away the same, but at 2 and 3-year survival. One way to deliver this higher dose that was similar to what was described has been continued by Dr. Crane and now led by Dr. Marcia Reingold at Memorial Sloan Kettering. And so this is a moderately hypofractionated regimen, 67.5 or 15, or most patients are getting 75 gray in 25 fractions. And here we're seeing an overall survival that's coming close to 30 to 40% at 2 years versus that 20% at 2 years. This, I think, is an excellent instructions on how they planned ablative radiation that's fractionated. So what you see is that there are a couple of volumes. Let me close this so that we can see more of the screen. I'm going to concentrate on the 25 fraction regimen because I think this is something that may be possible for more of you to implement. They do a microscopic extension PTV of 45 and 25, but then this high dose rate is going to 75 and 25. And if it's a very big volume, you can even do a smaller volume of 125. So this is a good picture of the low dose PTV, which is more like a traditional field. This would be, this green is around the tumor, and that would be the 75 and 25. And this small area of red might go up to 100. For 25 fraction treatments, you'd limit the duodenum to less than 60 gray, small bowel to 55 gray, and large bowel to 65. And notice they mark using a PRV. We'll talk about that here. Now, another study that we did that showed kind of this higher dose radiation, this is what I was involved in, which is SMART. But this SMART, where we did 50 gray in 5 fractions, this was with a very special machine where we were adjusting all the tumor and organs at risk in the same fraction. So we were essentially doing a simulation with each treatment. We could make all of these adjustments and create this new plan. The patient would be on the table for an hour. And then during the radiation, we could actually see with the MR exactly where the tumor is. The important thing that we take here, Mike Chung, my colleague, ended up updating, and we could see that even in patients who didn't have surgery, as we get to around that 2 years, we're getting a little bit higher than 20%, maybe 25% overall survival. And importantly, even with the high radiation dose, very low rates of possibly related radiation toxicity. This is another study that looked at patients getting 50 or 55 gray in 5 fractions. This was looking at a drug. The drug did not end up working, but importantly, it gave us information on how to do this type of radiation more safely. We had to give contrast either at the simulation or fuse a contrast image at simulation. We needed the respiratory management. Patients needed to have a stent or fiducial marker, and we had to have a high-risk volume that was not necessarily the tumor between the celiac axis and superior mesenteric axis. This is a good example of why you need some sort of marker to set up a patient. This is a patient of ours who had this marker placed. What you can see, let's see if I have the pointer, is that you can see on the simulation that the tumor was almost directly anterior of the spinal canal, maybe a little bit to the left. But if you look at the cone beam CT, you can see that the tumor, by virtue of the marker, has shifted 7 millimeters or so to the left. And if we set the patient up based on bony anatomy, we would not have set up the patient correctly. So this is why when you're doing this sort of treatment, you have to have some direct, more closer measurement of where the pancreas is. How did we simulate our patient? Arms up in an alpha cradle. We used IV contrast. And for this patient, it was a coached breath hold. And so we used an end exhale breath hold. These are the planning parameters, where we had a liver mean dose, kidney mean dose, and spinal cord dose. And then you see that I have doses to a PRV for the bowel. And in our institution, we keep these all the same. It makes it easier. It might be a little bit too tight for colon, but anyway, 33 gray has been kind of our magic dose. So let's look at what the tumor volume looks like. You can see this here in red that we're covering the whole pancreatic head tumor as well as then the blood vessels that are involved. But we have to be more careful about these organs at risk. I had a resident do a study who looked at daily imaging of patients who are getting radiation, and they were getting a daily MRI, and they drew the stomach and bowel every day. Lots of 5 times like 20 images. So this was a lot of drawing. What they found was if you were to create a full PRV of that motion, if you wanted to make sure that you captured all of it, you would have to expand the stomach by 15 millimeters, duodenum by 8 millimeters, and small and large bowel by 17 millimeters. This is far too big. You'd never be able to treat any tumors if this is the amount of concern that we had. Instead, to be more practical and avoid a high-dose region, we contoured the organs at risk and expanded them by 2 to 3 millimeters to create the PRV. So you can see here that the stomach is expanded, the duodenum is expanded here, the small bowel is expanded, and here we have some large bowel that's expanded. And we see some of the other views as well. Our tumor, of course, is still right here. So you can see how the gastrointestinal organs at risk are very, very close to these pancreatic head cancers. When I think of how to evaluate the plan, we mentioned that we allow 33 gray to go to a half cc of any of these structures. And so when looking at the plan, we want to make sure the 33 gray line just touches the edges of this. So we know that we were trying to get the most radiation dose to the center of the volume. So here, you can see how this blue 33 gray isodose just wraps right on the edge of the duodenum here in yellow, and then the stomach here in orange, and the small bowel here in pink. The colon in this patient is not something that's going to limit this patient's radiation. One of the hardest things for people to appreciate with pancreas high-dose radiation is that we do not cover the tumor very well. Only parts of the tumor get covered. So here I have the dose volume histograms of the CTV and the PTV, and then I also just put the PRVs to show you those. I put the blue isodose, this dark blue isodose is the prescription dose of 50 gray, and you can see that it's smaller than the CTV and doesn't come anywhere near the edges of the PTV. And you can see this in this axial plane, and you can also see this in this coronal plane. So our CTV has about 77% coverage at 50 gray, but our PTV only has 59% coverage. So what we're doing with these high-dose pancreas plans is we're not giving the whole pancreas tumor that prescription dose. That would be unsafe because the organs at risk are too close by. We are trying to get 60 to 90% of the CTV, that high-dose CTV, to get the prescription dose. And so this is something that we would really see. And you know, this is very different than when we plan homogeneous treatments where we're getting 95% of the prescription to the target. This was a patient that was set up with respiratory gating. I took this picture for this class. You can see that the patient's breathing is out of the area, and here in yellow, it's in the area. When we watch this movie again, I'm going to see if you can watch the bottom of the stent, that it's fine here, but when the patient takes a breath in like this, then it's outside of the planned area. And only when they exhale and hold their breath is it in the safe spot. So each day we set this blue and red. Basically, the beam only turns on between the blue and red. We set this with the breathing every day because it does change. But you can, it's nice to see with fluoroscopy and this stent how easy it is to see a measurement of where the tumor is. So that's pancreas cancer. I now want to go to advanced liver cancer. Here I have a 62-year-old with a history of alcohol use and hepatitis C. His liver function is not good. He has ascites and needs paracentesis or drainage of the fluid. But he presented with new and worsening right upper quadrant pain. You can see that this was biopsied and found to be hepatocellular cancer. The imaging report said this was a cirrhotic liver with ascites, but also you see many of these observations in the right lobe, replacing greater than 50% of the right hepatic lobe. What is your management for this patient? All right. Again, we're past 80%. We can finish the poll. So radiation supportive care, and then matched by either chemoembolization or the use of these two medications, atezolizumab and bevacizumab, and then supportive care. Let's talk about some of these options. So supportive care is always an option when you have a patient who is this ill, but we're going to talk about why we'll use radiation therapy and supportive care. It's interesting with the transarterial chemoembolization. If we look back, these tumors are hypoattenuating. I should have mentioned that this is an arterial imaging, and you can see that it's not picking up the contrast very well, which is unusual for primary liver cancer, but can happen. So I don't think that these would actually work because chemoembolization or any liver-based embolization therapy goes through the hepatic arterial system. And so if the hepatic arterial system does not get to the tumor, the treatment doesn't get to the tumor. For atezolizumab and bevacizumab, this is a good first-line systemic agent for a regimen for advanced liver cancer, but the patient's liver function is not good enough for safe administration. This is limited currently to patients with Child-Pugh A and is being evaluated in Child-Pugh B6 liver function. This patient has Child-Pugh B9 versus, that's close to Child-Pugh C, and it's not thought that atezolizumab and bevacizumab would be safe. Why are we now advocating for palliative radiation for a patient who is really quite ill? This is a recently published randomized study led out of Princess Margaret Hospital in Toronto. It looked for patients with liver cancer or liver mets with stable pain greater than 4 out of 10, with the largest pain burden in the liver. So our patient with over half their liver, definitely fits this. And they were not going to be suitable for any other types of therapy. Patients were randomized between best supportive care or 8 gray in a single fraction in best supportive care. And they assessed the pain on day 30 and on day 90. This is from the paper that was just published within the last 4 to 6 weeks. 16 of 24 patients who received radiation therapy and supportive care had a reduction of pain, so nearly 2/3, versus less than a quarter of patients with supportive care alone. They measured these quality of life measurements. When the axis goes down in the quality of life, it means your quality of life is worse. And if it goes up, it's better. And so what you can see in this change from baseline, both at 1 and 3 months, that patients who had radiation at 1 month, a lot of them felt a little better. And at 3 months, they felt a little better and a little bit worse, but not anywhere near as worse as the patients who had supportive care alone. One of the most interesting things about this, as there have been now other studies with incorporation of supportive care into their treatments, even in advanced cancer, is there was an improvement in overall survival. So that radiotherapy plus best supportive care had a median survival that ended up being around 5 or 6 months versus patients without had a median survival of around 2 months. This wasn't, it was a trend, it's P equals 0.07, but it shows, even the benefit of such a simple treatment. So this is what we did with our patient. The patient was pre-medicated with 4 milligrams of dexamethasone and 8 milligrams of ondansetron 1 hour before treatment. This does not need anything fancy. So, I just showed you this very fancy case of the pancreas cancer. I feel that this case, these are patients that you will see with liver cancer in the Ukraine. And even though you may not be able to meaningfully extend their life, you can improve their quality of life with the simple 8 gray in a single fraction. Also, it was, helpful for me when I read this study. I didn't appreciate that it was safe to give this much of the liver 8 gray in a single fraction. If you look at the details of the paper, the normal volumes were anywhere, they came around 1,500 to 2,000 cc's. So they were all big volumes like this. Now let's talk about liver SBRT. This is a 65-year-old with cirrhosis due to alcohol use and non-alcoholic steatohepatitis. I think this used to be called fatty liver disease. The patient was noted to have hepatocellular carcinoma and Child-Pugh class B with just a high bilirubin of 3.7 and a slightly low albumin. The patient was noted to have a 2.1 centimeter LR5 lesion and a 1.3 centimeter LR5. LR5 means that the lesion enhances and washes out, enhances on the arterial phase and washes out on the venous phase. We can actually see that for this this one here. I showed one of the this is the segment 4A lesion. You see the enhancement, and then you see that it's a little bit darker, and this is characteristic of hepatocellular cancer. But this tumor up here didn't have any clear hyperenhancement. You couldn't really see it becoming really much brighter, and it had a mix of bright and dark areas here in the dome. And so since this was an indeterminate lesion, a biopsy was done, and this showed hepatocellular cancer. The patient was referred for local treatment of his lesions because we wanted to downstage the patient for liver transplant. We offer liver transplants for patients who have tumors that are up to 3 tumors that are 3 centimeters or less. What would you like to do in terms of the management for this local? Yes, I made a long one here. Let's make it bigger. All right, we're there at that 75%. We can end the poll. So most common was radiation to all 3 lesions, followed by a mix of therapies, then percutaneous ablation to all 3 lesions, and arterial embolization to all 3 lesions. Okay, let's talk about some of our thought processes here. So if we did radiation to all 3 lesions, the patient would end up having areas around each tumor that would have a high mean liver dose. And it's the mean liver dose that's related to the toxicity in these patients. So this was not thought to be a safe treatment for the patient. If we look at percutaneous ablation, 2 of the lesions are small, and that could be a consideration. But the lesion that was 4.8 centimeters, this is too big for percutaneous ablation. There's a very much higher recurrence rate when lesions greater than 3 centimeters undergo ablation. Arterial embolization, this kind of goes back to the prior question. If you don't have an artery to the lesion and that dome lesion didn't have the enhancement, then it's not going to be as effective. So we did choose different therapies to each lesion, or we had SBRT to the large lesion at the dome and embolization to the other 2 lesions. So this is interesting because, as Dr. Shepil mentioned, I am sure that you are not asked very often to treat liver tumors with radiation because we have different areas. And so it really, really depends on where the liver tumor is. So we have livers at the dome that can be hard to reach with a percutaneous approach. Those can be good for radiation. This was, in our patient, we had a tumor that we would say is too large for radiofrequency ablation. Sometimes tumors near the vasculature, they could have some sort of heat sink. And there's been some studies about looking at patients for radiation with portal vein thrombus. In terms of chemoembolization versus SBRT, there have not been many comparative studies or randomized studies. This is the only one that I can find, and it was actually stopped early due to lack of accrual. And what you can see, very, very small study, right? 16 patients, 11 patients. You can see that the percentage of patients free of progression or free of needing another therapy, it was improved in the patients with SBRT versus chemoembolization. So let's talk about what dose, which option is an ablative dose, but also a safe dose for SBRT for this patient, for a patient, let's say, who has Child-Pugh A cirrhosis. Okay, we're past the 75%. We can end the poll. So let's see. So very even splits. Okay, the 21 gray 3 fractions. We have 25 and 5. We have 50 and 5, and we have 60 and 3. Okay, so let's see what we want to talk about here. So the answer was 50 gray and 5 fractions. And for I was supposed to change it. Where Child-Pugh B would be about 10 gray. So let's look at some of these references. There are different mean liver dose constraints based on a patient without cirrhosis and then a patient with cirrhosis, and even some interest between cirrhosis for Child-Pugh A versus Child-Pugh B. So this is from a recent ASTRO radiation oncology guideline for liver cancer, published in Practical Radiation Oncology. There are many references that try to gain this, so I just took the overall table. But again, for patients, say, with metastasis, you can look at a mean liver dose of 15 to 18 gray in a 5-fraction regimen. For Child-Pugh A, I tend to use 15 gray as my mean liver dose. And then for greater than that, I try to use 10. So here, for this patient, they did have Child-Pugh B, 50 gray and 5 fractions, 10. Let's look at the other answers. The 21 gray and 3 fractions is an old liver dose that we use to treat the whole liver. So this was used in studies 20, 30 plus years ago for palliation of disease, and they found that 21 gray and 3 fractions was tolerated. 60 gray and 3 fractions would be an ablative dose. It has a BED of maybe 120. But this mean liver dose of 25 gray would be far too much and not safe for a patient with cirrhosis, and maybe not even safe for a patient without cirrhosis. Here, 25 gray and 5 fractions, that's not you need a BED of at least 80 gray. That tends to be used. So you need something 8 to 10 gray and 5 fractions. 25 gray and 5 fractions is good for rectal cancer, which is lower GI, so that's not my talk to give. Let's talk about this patient setup. 50 gray and 5 fractions, liver minus CTV of a mean dose of 10 gray. I added this V5 less than 60%, total kidney dose, spinal cord dose, and then the bowel doses. You can see how we set up the abdominal compression. We have to make a mark where you have this paddle that you blow up and where the belt is placed. And so we have instructions of how to put that up. This was the patient's plan. Since we were just doing the dome lesion, I've highlighted 50 gray, and I also did a 12 gray volume just to kind of show some of the low dose. And imagine if we had this sort of low dose volume among each of those other lesions. You could see how it'd be very easy for us to incorporate all the like too much liver. And here we had just a mean dose of 6.7 gray. So in conclusion, I think active respiratory motion management, we have to find one area of the breathing motion to deliver therapy on. I say the least expensive method is abdominal compression. I hope you are seeing that there's a role for palliative and definitive radiation for different types of primary liver cancer, and ablative radiation, either stereotactic or fractionated, is currently preferred in locally advanced pancreas cancer. Thank you for your very nice participation.
Thank you so much, Dr. Parikh. It was excellent lecture and we learned a lot. So we'll keep the questions till the end. Dr. Shepil, go ahead, share your slides. Dr. Shepil, you're muted.
Thank you, Dr. Parikh. Very great talk, very interesting and very useful. My clinical case about esophageal cancer case, because it's the most common case undergoing radiotherapy in our country. According to the data of National Cancer Registry, per year we have the incidence 1,450 patients and mortality more than 1,000 patients per year. 58% of patients live less 1 year in our country. Let's consider an example of the treatment of this localization. First case, it's a male for 64 years old, no smoker, no non-drinker, long time work at the railway roads as machinist, which may cause toxic load from fuel and lubricant material and dust. He began to examine it at his place of residence, after which he was referred to our medical institutions to consider surgical treatment. Histological conclusion was low-grade squamous cell carcinoma G1, G2. In CT scan, we can see the thickening of middle third of esophagus at the level of TH6-12. Extension was 165 millimeters. Also, we can see the lymphadenopathy of paraesophageal lymph nodules level TH8, TH9, size 22 to 14, 20 to 19 millimeters. Also, this patient has congenital deformity of the chest as a result of rickets. The diagnosis was cancer, the middle third of the esophagus, clinical stage T3, M1, M0, third stage clinical group second. The medical oncological council decided to conduct a course of chemoradiation therapy as the neoadjuvant treatment, external beam radiotherapy and chemotherapy using carboplatin, paclitaxel in first 8, 22 and 25 days. According to the recommendation of NCC protocols, we use the regime of single dose 1.8 gray, total dose 55 gray to the esophageal lesion and mediastinum nodules. Chemotherapy started on the first day. We use daily CBCT. Margin from CTV to PTV was 10 millimeters. And we use limited dose constraint for conventional fractionation. And the contouring here, you can see the margin you can see contouring of the CTV, it's orange line, and PTV, it's green, it's a red line for the primary tumors, and also you can see CTV for the zone of lymph nodules, it's a beige line, and the purple line, it's PTV to the lymph nodules. And after this, I combine this PTV to PTV all for the treatment. And the treatment plan, you can see the coverage of the PTV was more than 95%. And we use one ARCS and energy 6 MB. And questions about this clinical case. What is your perspective on treatment for such case? Please comment on chemotherapy options. Please comment regarding those that are recommended of definitive treatment according current trial and recommendation. And what is your option on performing brachytherapy boost in general for esophageal cancer? Thank you, Dr. Parikh.
Sure. Thanks for presenting such a very standard and common disease that we see in the upper GI. I agree with Dr. Shepil. It's the most common cancer in the upper GI system that we use for radiation. So my perspective on the esophageal cancer, things are changing as for adenocarcinoma. If the patient has adenocarcinoma and is a candidate for surgery, the new standard of care is induction chemotherapy alone. There is not a role for preoperative radiation for adenocarcinoma of the esophagus. This is after the recently completed study of ESOPEC, ESOPEC, which randomized patients between FLOT chemotherapy and chemoradiation and showed an improvement in patients who received FLOT chemotherapy. With regards to the chemotherapy options for patients, and so Dr. Shepil and I discussed this patient had squamous cell cancer, and for those patients, we continue to give preoperative chemoradiation. On the chemotherapy options, I think the carboplatin and paclitaxel is a very good one and likely the least toxic. We also have used 5-FU and oxaliplatin in these situations as well. With regards to the radiation doses, there have been multiple studies to see if we increase the radiation dose and we make anything better. And the answer is no. There is no role where we have found an increased radiation dose for esophageal cancer to improve outcomes. So treatment regimens of 45 to 50.4, maybe to 54 gray. I don't see any role of going above that. And frankly, I don't see much role of going below that either. This brachytherapy boost is a way to escalate the dose for esophageal cancer. I think it can have a role in patients with recurrent esophageal cancer farther after treatment, but the general use of including it after conventional chemoradiation, there was some older studies that showed this added to toxicity and didn't improve outcome. There's no study that I know of incorporating it in the first course to improve outcomes. So I think brachytherapy is a salvage treatment and not a boost treatment for esophageal cancer.
Thank you very much for the answer. And I have one more case. It's about multifocal esophageal cancer against the background of Barrett esophagus. Female, 64 years old, no smoker, no drinker. For many years, she had been observed with metaplasia of the esophageal, of esophageal region. Associated pathology is hiatal hernia. Gastroscopy show the lesion at the 21 centimeters at the apex of the metaplasia along posterior wall, size 10 millimeters. And second lesion is at the 27-29 centimeters in cross wall, and the sonography also reveals a hypoechoic formation in the mucosa and submucosal areas. Histological conclusion of both zones are low-grade adenocarcinoma G1, G2 in the area of metaplasia. We can see the result of gastroscopy, and our MDT recommended minimally invasive esophagectomy for this case. Questions about this case. What is your perspective in this case? Do you think radiation therapy is an option in this case? And if in this case we get the R1 resection, better options would radiation therapy or reoperation? Thank you very much.
This is a very interesting case where you have the multifocal adenocarcinoma, but both are T1 lesions. They do not go into the muscle layer. So I think I would agree with your MDT that in a healthy patient, an esophagectomy is the correct management. I would reserve radiation therapy as an option in this case if the patient was not as healthy and would not be able to tolerate a surgery. There, I do think you could use chemoradiation, the carboplatin paclitaxel 45 to 54 gray, or Folfox with 45 to 54 gray as an option in a patient who cannot have a surgery. I do think radiation or adjuvant radiation with chemotherapy would be a better option if there's an R1 resection, as trying to redo the esophagectomy or get new margins and a new anastomosis may be challenging.
Thank you very much for your answer. Thank you for your lectures, because lectures was very great and very interesting, I think, for all our colleagues.
Thank you so much. So we are opening the floor for the questions. So I see some comments in the chat. So Dr. Parikh, thank you so much for the great talk. Can you advise any options for radiotherapy for patients with non-massive esophageal hemorrhage? What's your maximum dose for cervical esophageal cancer?
Those are two very good questions. The first question, radiation therapy for slow bleeding of gastrointestinal cancers is so effective. And I always try to tell our colleagues who take care of these patients and our residents that they should be very quick to offer this because it can help a lot of our patients. A single dose of 8 gray and 1 fraction can help most patients. If I have a patient with esophageal cancer bleeding only, I might be fine with 8 gray and 1 fraction. If I have a patient who also needs some palliation for the bulk of the tumor and problem swallowing, then I don't use 8 gray and 1 fraction, but I'll do 20 gray and 5 fractions or 30 gray and 10 fractions. Most of these patients have metastatic disease or have poor prognosis, so I try not to extend the radiation very long. With regards to cervical esophageal cancer, this is a very challenging area. I will admit it's such a challenging area for me. I pass it to my colleague, Dr. Siddiqui, who treats head and neck cancer, because I feel this is much more like a head and neck cancer. I know in his experience, he tries to go to 66 to 70 gray in these patients, but it is not always easy to do so. Fortunately, such cases are quite rare.
Rare. Okay, excellent answers. I was also wondering about your approach for SABR for the pancreas. So here at Stanford, before we had a Marlinac, we used to treat them on TrueBeam, on basically expiration gating, right? Because at expiration gating, when the diaphragm goes up, then there is more space between the organs. So there is a more separation between the pancreas and adjacent bowels and so forth, right? From Taniguchi paper, there was a really nice study. And I was wondering, so you're treating patients on expiration breath hold, a 15-minute hold. How well is this tolerated?
So actually, so it's exhale, breath hold. We mark that it's a breath hold, but it is actually the gating technique that you described.
Okay.
So they're not holding their breath for 15 minutes, but they will relax on the exhalation, and that's when the beam will be on. we do have patients where we coach them into that breath hold versus doing the gating during a free breathing. And they can hold their breath for about 20 to 30 seconds at a time. That's what we assess to see if they're eligible for a coached breath hold.
I see.
But very similar to the treatment that you described on the TrueBeam and Edge, another good reason to use exhalation is that exhalation is a more reproducible state of breathing. So whenever we breathe out, exhalation, whether you force hold the breath out or you breathe out naturally, it comes to the same area. Versus when you inhale, you can have many different types of inhalation. So we found that to be less reproducible. But those techniques that you described, starting back with Dr. Kung and Dr. Chang and Dr. Taniguchi, we lost Dr. Taniguchi more recently, unfortunately. But a lot of really good pancreas radiation experts came from Stanford, and we use many of those techniques today when the patient's being treated on a standard LINAC.
Right. And so now you switch to MR, exclusively MR LINAC?
We are using MR LINAC because it's a great device to treat the upper abdomen. But for the purpose of this course, I found all these patients that we still needed to treat on a standard LINAC because not every patient is eligible for MR. They may have claustrophobia, and there was a time our MR was not available. And so I think we should not say that you need an MR. An MR LINAC makes upper GI radiation easy, but you do not need an MR LINAC to do upper GI radiation. And that's why I wanted to show cases today that did not involve the MR LINAC. I see a question in the chat for the 8 gray for stomach bleeding. Yes, I use 8 gray for stomach, colon, cervix.
Anywhere in the body.
Anywhere that's bleeding. I think 8 gray is still one of our powerful dose and fractionations we use to make people feel better. That sometimes, and especially, it's easy for the patient and it doesn't take many resources to deliver 8 gray in a single fraction.
Yeah, excellent. Any more questions? So I see, thank you so much. Excellent lecture. I also want to give a chance to the residents behind you to ask questions. Any questions in the audience?
Participated here, so.
I want to ask also Dr. Parikh about complication when you treated pancreas cancer. What complication you saw and how you decide this problem?
So that was the big concern about using such high radiation doses in the pancreas, that it would be very toxic. And that's why there is that necessary that you have to have a marker, you have to plan with contrast, and you have to have active breathing management. I think without those 3 things, then I don't think you can do it so safe. But in the studies that have been shown, in those experiences of using ablative radiation in the pancreas, we see things like nausea, but we have a less than 10% chance of duodenal ulcer, which we normally manage with supportive care, like antacid medication. Sometimes if there's bleeding of an ulcer, they go in with the endoscopy with the laser. I have not had a patient with like any sort of small bowel or duodenal fistula. Really fatigue, nausea, sometimes some central abdominal pain, and a chance of duodenal ulcer. Those are the most common side effects, but the severe side effects have been kept less than 10% really. So that was really surprising for us.
Yeah, in the beginning, when the Saber pancreas started at Stanford, they started doing it with CyberKnife, and the initial dose that they selected was 25 gray in 1 fraction, and that's where they saw fistula. So they had to fractionate more.
That's correct.
That's a historical perspective.
It is a historical fact. One thing, Dr. Shepil, that's actually going to happen here in North America, you showed that slide by Dr. Stanford, Nina Sanford there, that paper.
Mhm.
She is actually going to lead a randomized study between ablative radiation and pancreas cancer versus chemotherapy or conventional chemoradiation, trying to show in a national study here in the United States and North America whether we can show that difference in survival. So that's going to be an ongoing study over the next few years.
She's at UT Southwestern, correct?
That's correct.
And anything else exciting that you are hoping for or looking forward in the future for, let's say, liver? Any
There,
trials?
so I think there's going to be some studies about incorporating immunotherapy and liver SBRT to see if the combination of the two are better than the systemic therapy alone. This was actually shown that liver radiation plus sorafenib was better than sorafenib alone in patients with advanced liver cancer. So we are looking to open that study on a national level, will open in probably 6 months. Again, to better show the role of radiation in primary liver cancer. But on a day-to-day, because we have interventional radiology, which does a very good job with liver cancer, with ablation and embolization, that we have to be thoughtful of which liver cancers we think are good for radiation versus ones that are fine being treated somewhere else. And that's where that slide about location, I think, is very helpful.
Do you have a very busy liver embolization program at Henry
We
Ford?
do. So probably for every week, we
Mhm.
have a liver tumor board that lasts 1 hour.
Mhm.
At that, I would say that we probably present, let's say we present 7 patients. 3 or 4 would get embolization.
Mm.
One might get one or two might get surgery or ablation, and then one will come to us for radiation. That's about what,
Okay.
right? Those
That
of you
sounds
gonna,
accurate.
yeah.
I had one question.
Yeah.
For, as someone that may practice in a more rural area without a VRay, I know we discussed this before, but what were the challenges in using the compression belt and training staff? And then what percentage of patients do you think overall were able to effectively utilize the compression belt and tolerate it?
So in our experience so far, we've had about 2/3 to 3/4 of the patients tolerate the compression belt. But I have colleagues over in the UK that have a much better rate of having those patients. And I might have been overly ambitious about how to put it on so tight. So even when now in the last few patients, I've just put it moderately tight, and that's reduced motion from like 8 millimeters to 5 millimeters. And I don't try to tighten it more than that. That's improved tolerance. I think it's actually pretty easy for the staff to learn, and it's much easier to learn than the gating systems, which involve a lot more technology. Because once you have a patient under compression, when you set them up at the machine, it's very straightforward. While if you use surface gating or a motion monitor or an ABC device, that's a lot more cumbersome.
And I have a question too. So I didn't have a chance to go to cases at the CT, all like cases I had with you on the Bureau. Is there like any difference on like the margins, CTV, BTV margins between CT and MR?
So good question about CTV and PTV margins that I use on the MR Linac versus on a conventional Linac. And yes, so I tend to use a 3 millimeter margin on the MR Linac and a 5 millimeter margin on a conventional Linac, just because of the challenges with localization.
And for the compression belt, we bought the compression belt, but used it only for one patient, unfortunately. So we do everything gating or breath hold otherwise, and only use compression belt for reflection machine that does not have motion management yet. Right. But for compression belt, you still acquire for DCT, correct? To examine motion. And how difficult is it to acquire for DCT for this
Those are
small
good.
amount of motion? Yeah.
That's a good question. So when a patient has a compression belt and you try to measure the abdominal motion to get a 4D CT, it's not moving much because it's compressed, and sometimes you cannot get a signal. In those cases, we just end up taking 3 CTs in a row to sample the breathing, and that is then sufficient for us to measure the motion. We use our compression belt, Natalia, on our Ethos machine. That
Okay.
also doesn't have
Does
any
not have
respiratory
got
gating.
it.
That's
Yeah, that makes
correct.
sense.
But because we used it for that machine, we also then learned to use it. We have different sites that have different technology, and the compression belt, you know, makes it easier for some sites that don't have gating either on a regular Linac. And it's cheap, it's inexpensive. You know, that does not cost so many tens of thousands of dollars that the other systems do.
Yeah, I think it's a good solution for Ukraine. So I see some people are even asking me to send our compression belt to them. So that's awesome. Okay, excellent lecture. If there are no more questions, thank you so much for this very informative, great lecture today. Thank you for teaching us, Dr. Parikh and Dr. Shepil. It was really great. I would like to take a group photo if people don't mind turning on their cameras. I'll just capture the photo. Please turn on your cameras. Excellent. It's so nice to see you all. Thank you for joining our lecture today. It was great participation. Thank you. So say smile. Great. Beautiful photo.
All
I'll
right,
share it
thank you.
with the group. Thank you. Thank you. Have a great rest
Thank
of
you
the
very much.
evening. Bye-bye.
Okay,
Have a
bye.
great rest of the day. Bye-bye.
Bye.